From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor at JAMA, and I'm joined today by Dr. Norbert Stefan from the Division of Endocrinology, Diabetology, and Nephrology at the University Hospital of Tübingen in Germany. Today, we will be discussing a JAMA article that he co-authored with Drs. Herbert Tilg, Salvatore Petta, and Giovanni Targar, titled Metabolic Dysfunction-associated Steatotic Liver Disease in Adults, a Review. This article was published online in JAMA on November 10th. Dr. Stefan, thank you so much for joining us on this podcast.
Thank you very much, Dr. Walters, for having me.
So to start off, metabolic dysfunction-associated steatotic liver disease, also known as MASLD, was formerly called non-alcoholic fatty liver disease and includes conditions ranging from isolated hepatic steatosis to metabolic dysfunction-associated steatohepatitis, or MASH, and cirrhosis, which can progress to hepatocellular carcinoma. Can you describe the prevalence of MASLD worldwide in the general adult population, and is its incidence increasing or decreasing globally?
The prevalence of MASLD in adults globally ranges between 30 to 40%. So it's a quite large number. And during the last 2 decades, the prevalence almost doubled. So it's increasingly being viewed in the field of internal medicine.
And the prevalence is substantially higher among individuals with metabolic diseases. Can you discuss how common MASLD is among individuals with obesity and those with type 2 diabetes?
Indeed, this is also why the name and the definition of this steatotic liver disease in 2023 actually changed. It was renamed from non-alcoholic fatty liver disease to metabolic dysfunction-associated steatotic liver disease, MASLD, and particularly because it is strongly related to metabolic conditions and metabolic diseases. This is also due to the fact that the prevalence of MASLD is particularly high in people with diabetes. About 60% of people with type 2 diabetes have MASLD. And the prevalence is even higher in people who are obese. So in obesity, the prevalence of MASLD can increase up to 70 to 80% of the obese population.
Your article also mentions that there are substantial geographic variations in MASLD. Can you discuss which areas of the world have the highest and lowest rates?
Very high prevalences are in Eastern European countries, also are in South America, and particularly increasing, starting from a lower number, but heavily and strongly increasing is the prevalence in Asian countries. Here, particularly in China, where the prevalence actually more than doubled during the last 10 years. So regions where obesity, overweight, and type 2 diabetes is very prevalent, they have a high rate of MASLD, but unexpectedly also in the more leaner populations in Asia, the prevalence increases.
And the most important clinical risk factors are abdominal overweight or obesity, insulin resistance, and prediabetes or type 2 diabetes. Can you discuss this further? And does the risk of developing MASLD and progressing to MASH increase with more metabolic syndrome features such as hypertension, hypertriglyceridemia, or low HDL?
In fact, that's very important because the pathogenesis of MASLD is very heterogeneous. So let's start with the MASLD that's in most cases purely genetically determined. It's about 30% of the population with MASLD. So these people have most cases some genetic problems of triglyceride release from the hepatocytes. So these people, in most cases, are not overweight or obese and don't have severe insulin resistance. But here I'm talking about a smaller part of the MASLD population, 25 to 30%. But 70 to 75% of the MASLD population has other risk factors for MASLD. And these are, in most cases, dysfunctional adipose tissue, meaning White adipose tissue, particularly in the subcutaneous area, is a perfect storage of lipids. So in young people, the subcutaneous fat is the sink where energy is being stored and doesn't make you ill. However, during aging, the hormones decrease, in most cases the sex hormones, in women estrogen, in males testosterone, resulting in an increased insulin resistance in adipose tissue. So the lipids that are being stored there are being drained to the liver and don't find any other places around the body in the subcutaneous tissue, and then are being stored in the liver, inducing MASLD, but also in the visceral compartment, the visceral fat, where they stay for some times after a meal, but are then again being released. So this dysfunction of adipose tissue that happens during aging is one of the most important reasons for MASLD. The other, also related to this 75% of overweight, obesity, and insulin relevant, is related to increased intake of fructose, increased intake of glucose, and increased intake of saturated fat. So we have the problem of new buildup of fat, particularly from glucose and fructose, increased de novo lipogenesis. Then we have the adipose tissue dysfunction. These are actually the main causes for MASLD that is related to metabolic diseases and obesity.
So you mentioned the high intake of fructose and high-calorie diets as being a risk factor for MASLD. Can you also discuss some other behavioral factors associated with an increased risk of this condition?
From behavioral factors is certainly also the increased alcohol intake. So I would consider this also a behavior and lifestyle factor. And before 2023, researchers and scientists tried to exclude alcohol conditions, saying alcohol is a different entity of steatotic liver disease. But we know now that this is a continuum. So there can be an increased alcohol intake, then also driving a new lipid buildup in the liver. So whenever there is a little increase or moderate increase in alcohol intake, the reduction of alcohol intake will always help reducing the steatotic liver disease. Then we would consider more of a behavioral aspect is certainly the sedentary lifestyle. And this is a huge problem because particularly in our younger patients with MASLD or even in adolescents, we see that MASLD strongly not only relates to obesity, but to a low physical activity. And so in the treatment of MASLD, just increasing muscle exercise capacity and physical activity within 1 week can reduce liver steatosis to about 20% without any change of body fat mass. So this is the support that increasing lipid burning in skeletal muscle drains fat out of the liver. So the sedentary lifestyle, the low physical activity is also, in addition to an inappropriate diet, a very important risk factor for the fat accumulation in the liver.
And I want to circle back to alcohol for a moment. Your article describes a condition, metabolic dysfunction and alcohol-related liver disease, or MASLD, which is a different category of individuals who have liver disease with both metabolic syndrome and alcohol. Can you describe this condition, why it's important to differentiate MASLD from MASLD?
It is important because the MASLD is something where we can focus and work with our patient and put a lot of focus on reducing the alcohol intake. And we all know that's not easy. So reducing alcohol intake in people who are used to high intake of alcohol is a long-lasting point. So whenever we try to treat our patients with MASLD with lifestyle changes on improvement of glucose and lipid metabolism, but don't focus on reducing alcohol, we will not be successful. Therefore, it is important to still separate, not that strong as we did during the past 10 years, but now the more the metabolic related and more the alcohol related. And therefore, it is important to reduce the alcohol intake because if successful, it's a very easy target to achieve.
And moving on to symptoms, do patients with MASLD typically present with symptoms, or is it usually identified incidentally?
Unfortunately, in most cases, it's really incidentally. So there are reports, particularly when MASLD is in an advanced form. So when inflammation is already there, metabolic dysfunction-associated steatohepatitis and early fibrosis, then the liver gets bigger and bigger. It induces some pain in the right abdomen. People develop a little bit of a fatigue, but as we all know, these are very unspecific symptoms. So in more than 50% of people with MASLD, they don't have any symptoms at all. And so MASLD is either diagnosed by specific testing or by chance, in most cases, by an abdominal ultrasonography.
So that leads to my next question, which is how is MASLD diagnosed?
In most cases, it is abdominal ultrasonography. It's a very reliable, very sensitive tool to diagnose moderate and advanced steatosis. It's not that good to diagnose mild steatosis. But on the other hand, mild steatosis is not the big problem. And mild steatosis again may become a problem if the liver is severely diseased. If there's a lot of fibrosis, then the lipid content decreases. But for a general setting, in a mild steatosis, if there is no advanced liver disease, is not that problematic. And moderate and advanced steatosis can be very well diagnosed with ultrasonography. So this is the first and most reliable diagnosis. Then there are scores that can be used. For example, the fatty liver score. Those scores use triglycerides, BMI, liver enzymes, waist circumference. So they can be used, but are not that reliable than ultrasound.
So you mentioned that the sensitivity of ultrasound for detecting mild steatosis is not great. What are some other non-invasive measures to assess hepatic steatosis in those patients?
Other measures are computed tomography. It's not recommended to perform computed tomography based on the radiation to just diagnose steatosis. But many of our patients in the diagnostics undergo CT. For example, search for gallstones, for search of cysts in the kidney, and so on. So it's always worth, and this is why I'm telling my fellow radiologists to go back and look on their CT scans whether the patient has MASLD. So CT is a good tool, but shouldn't be recommended as a screening if there are no other reasons for doing that. And the third and very reliable tool is magnetic resonance imaging and spectroscopy. So this non-invasive and safe method very precisely also identifies very early stages. It is being used for monitoring of treatment of MASLD. And the prices, certainly it's the most costly diagnosis, but in most cases, the prices go down. And it may be that in the next years, MASLD is much more often diagnosed using magnetic resonance imaging or spectroscopy.
Can you describe the most commonly used non-invasive test to evaluate fibrosis severity in individuals with MASLD?
The most often used non-invasive test to diagnose fibrosis is the fibrosis 4 score or FIB4 score. The FIB4 score is calculated using age, ALT, AST, and the platelet count. And here we have three areas. We have people with fibrosis score lower than 1.3. And here advanced fibrosis is in most cases excluded. Then we have an intermediate risk state that is 1.3 to 2.67. Here, further testing should be recommended. And then we have the area of higher than 2.67. And here, the risk for advanced fibrosis is very high, and 5 to 10% of the patients have this high score.
And can you also discuss the enhanced liver fibrosis test? When should that be performed?
The enhanced liver fibrosis test is a test with 3 blood-based biomarkers and is recommended to be used after the fibrosis 4 score. So if people are in the intermediate or in the high range, and here it has a good sensitivity and specificity to exclude or diagnose advanced fibrosis. And it is not only this ELF test, but it's also the vibration-controlled elastography that has the same power of detecting advanced fibrosis. That's a tool where liver stiffness is being directly measured with a tool like an ultrasound.
And when should liver biopsy be considered to diagnose MASH and stage hepatic fibrosis?
A liver biopsy was much more often used, let's say, 5 and more years back. And hepatologists now very seldom use liver biopsy, and liver biopsy is being used when the diagnosis is not clear. When there is a risk that autoimmune hepatitis is prevalent, when there is a mixture of hepatitis, viral hepatitis, for example, hepatitis C, and possibly autoimmune related diseases, and when there is a very quick progression of inflammation and fibrosis. So in summary, the liver biopsy is, compared to 10 years ago, no more primary diagnostic tool to estimate the severity of MASLD.
And how commonly do patients with isolated hepatic steatosis progress to MASH, advanced fibrosis, cirrhosis, and hepatocellular carcinoma?
So with isolated steatosis, many people remain asymptomatic for their whole life. But there is a progression of about 7 to 35% to metabolic dysfunction-associated steatohepatitis. So at the very end, from the people with MASLD, 30% have MASH. Then what is really worrisome is the progression to hepatocellular carcinoma. So from MASH, small proportion, about 0.2% progress per year to hepatocellular carcinoma. But when already cirrhosis is there, this percentage is much higher. So it's not 0.2 per year, but it's about 2.5 per year. So there is a progression, and that is being now viewed much more often than experts expected, that the stage of fibrosis and cirrhosis needs not to be passed. And some people really have the problem that inflammation already triggers this cancerous process that then results in hepatocellular carcinoma.
So moving on to behavioral modifications, we know that's the first-line treatment for MASLD. Can you discuss dietary and physical activity recommendations and how effective are they?
The best data comes from studies that addressed weight loss. And it's commonly accepted that weight loss of about 5% is quite effective of reducing about 20-25% of steatosis. 7 to 10% weight loss is necessary to reduce to a considerable amount inflammation, and 10 to 15% is now necessary to really reach a regression of fibrosis. So weight loss, particularly in overweight, in obese people, about 10%, let's say that, and in some people higher, is very effective. We know that also a modification of lifestyle and the diet without weight loss is effective. And here is particularly the modification of the diet, moving more to a Mediterranean-like diet, meaning healthy oil and fats, a reduced intake of saturated fat, particularly from meat, and particular reduction in fructose and glucose also can have pronounced effects on steatosis and also inflammation without any weight loss. So the recommendation is in overweight and obese people to reduce body weight, aiming at about 10%. But in addition to that, the modification of the diet is also effective. And the last point, certainly, the increase in physical activity is also helpful to achieve an improvement of the MASLD.
The U.S. Food and Drug Administration has conditionally approved two medications, resmetirom and semaglutide, for treatment of adults with non-cirrhotic MASH and moderate to severe fibrosis. Can you discuss these medications and what is the evidence supporting their use?
People working in the field of MASLD have very long waited for approval of drugs for treatment of MASLD. And the first drug approved in 2024 in springtime from the FDA is resmetirom. It is a thyroid hormone beta receptor agonist that increases lipid oxidation in the hepatocytes. So the phase 2b and then the phase 3 study with resmetirom in people with MASH and F1 to F3 fibrosis showed, the biopsy-based study and outcome showed, compared to the placebo, the doubling of the improvement of resolution of MASH, around 35-40%, and also an improvement of fibrosis. So particularly the phase 2b and the phase 3 study were the studies that led to this conditional approval of resmetirom for the treatment of MASH, and it is approved for F2 and F3. So people need to have MASH and F2 and F3 fibrosis. So fibrosis diagnosis is very important to use these drugs. The second drug that has been approved by the FDA is semaglutide, is the GLP-1 receptor agonist that is being for several years now being used to treat type 2 diabetes, then also to treat obesity. And this drug semaglutide in a large phase 3 study also showed very strong effects of improving MASH, leading to resolution of MASH and also improvement of fibrosis. Therefore, these two drugs have been approved by the FDA, and in Europe, resmetirom so far is being approved, and we'll wait whether semaglutide will also be approved.
Which patients with MASLD should be considered for bariatric surgery?
For bariatric surgery, mostly the people with severe obesity. It's like the recommendation to treat type 2 diabetes. So in most cases, people with BMI 40 or higher, those should be very early evaluated for bariatric surgery. But if the disease is severe, the recommendations worldwide also address people who have a BMI of 35 already and higher. So the more severe the MASLD disease, it may also be already important in people with BMI of 35 and higher of thinking about a bariatric surgery in those people.
Before closing, is there anything that we didn't discuss in this podcast that you'd like to mention?
What I like to mention is being a physician treating these patients every day. It is very important to focus on MASLD in our patient with obesity, in our patient with diabetes, because MASLD for our patients is a disease that is very, let's say, visible for them. So they see the ultrasound signal, they see the results of the tests. And I use it often as a motivation of changing lifestyle, of starting exercise, and also in some cases when it's necessary to use pharmacological treatment. So MASLD is so widely in the lay public a disease that our patients very well understand. So using it and addressing it and saying we improve with the lifestyle change, for example, your liver, your fatty liver, and we try to reduce the fibrosis progression. This is something that I can use much more than as an endocrinologist focusing on the HbA1c. Therefore, this is important, this motivational aspect, talking with the patients who have this problem of the fatty liver, but we want to get rid of it, and the chances are quite good. So this is actually a positive message that I very often use with my patients, and in most cases, it is also successful.
And just to follow up on that, how often are you getting repeat ultrasounds in patients with MASLD?
The repeat ultrasounds are actually, patients ask me for that. So after they come back after 3 months, or in most cases 6 months, they say, I lost some weight, I changed my diet, but now I want to see how my bright liver changed to a dark liver. So therefore, I use the ultrasound very often. It is an educational, it's a motivational aspect, and it is putting hands on the patient. Therefore, ultrasound in my clinic is very important because I don't only look on the steatosis, but certainly I also want to see whether there are changes in the liver, on the structure in the liver. Certainly want to see, if possible, early development of cancer and so on. So the ultrasound in my hands is very important.
And you're getting that at intervals about 3 to 6 months or less often?
No, like 3 to 6 months. This is when it's reasonable to do a checkup, and it's actually not necessary repeating it after 8 weeks or so.
Thank you so much for sharing your thoughts with us about this interesting and important topic. I'm Dr. Kristin Walter, and I've been speaking with Dr. Norbert Stefan from the Division of Endocrinology, Diabetology, and Nephrology at the University Hospital of Tübingen in Germany. You can find a link to this article in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.